Welcome to everyone to my presentation. I am Dr. Afroza Aktar from Nuclear Medicine, Institution of Nuclear Medicine and Allied Science, Dhaka Medical College. I am not cardiologist, I am a nuclear medicine physician. So I am presenting my presentation, Comprehensive Assessment of Myocardial Viability in Left Bundle Branch Block. Assessment of myocardial viability in presence of left-bundle branch block can be tricky, particularly in the context of dilated cardiomyopathy and coronary artery disease. Here I am going to share two such cases of LBB patient highlighting the role of nuclear imaging technique for comprehensive assessment of myocardial viability, its impact on clinical decision making and guiding management with different outcome. My first presenting case, a 55 years male who presented with exertional chest pain and palpitation for 3 months. He had several comorbidities like hypertension, diabetes, and dyslipidemia, and some medications. When he presented with chest pain, his troponin I level was normal. Hemoglobin A1C was also normal, but in ECG there was LBB. There was white QRS complex in the limb and chest lead, and QRS duration was 169 milli per second. In left bundle branch block, there is usually septal delayed activation, which causes the pattern of white QRS complex. So, on echocardiography, the comment were ischemic cardiomyopathy, severe LV diastolic dysfunction, and reduced ejection fraction of about 30%. Hypokinetic anteroseptal inferior and posterior valve. Then this patient was referred to us for myocardial perfusion and viability imaging. The first one is the perfusion imaging. Perfusion imaging shows quite normal perfusion, only small amount of septal anteroseptal defect in the LAD territory. When we perform the FDG cardiac PET viability imaging, there is a large metabolic defect. You can see the second picture, the large metabolic defect involving the anterior, anteroseptal, inferior and infroseptal valve. That means in the LAD and RCA territory. And the lateral valve shows normal metabolic activity. Then we have done the MPI and FDG cardiac PET fusion imaging. When we fuse the first this polar map, blackish polar map, the FDG PET imaging, middle one is perfusion imaging. When we match these two imaging modalities, there is a reverse mismatch pattern in the LAD and RCA territory. Reverse mismatch pattern, that means preserved perfusion and reduced metabolism, which indicate the stunned myocardium. And on fusion imaging, we also show that there is reduced ejection fraction. After that, after this imaging modality, patient underwent coronary angiogram. Interestingly, on angiogram, there was normal left main, LAD and RCA territory and minor plaque in the ostial part of the LCX and mid part of the LCX. This patient was advised for medication, and we have followed this patient after 1 year. We can see we have done the follow-up with MPI imaging, REST MPI. We see that there is LV cavity dilatation, which was previously is 114, which turned into 178, and persistent septal valve dyskinesia. And the amount of septal valve dyskinesia is raises compared with the previous one. So, for perfusion and metabolic imaging in LBB patient, it's important to consider that delayed activation of septal electrical impulse leads to delayed asynchronous septal contraction and reducing the metabolic demand, which significantly interfere with image interpretation. CRT therapy may be recommended to treat such heart failure patient suffering from conduction abnormalities like LBB. Now, I am going to present my second case. He was a 74 years male. He also presented with exertional chest pain for last 3 months with several comorbidities, hypertension, diabetes, dyslipidemia, and COPD. This patient gave history of incidental diagnosis of LBB in 2015. He had history of hospital admission due to DCM and reduced heart ejection fraction 30% in January 2016. During that time, his coronary angiogram was normal. But recent laboratory parameters revealed raised troponin I level 2.19 nanogram per ml and markedly raised NT-proBNP level. After that, on echocardiography, there was dilated cardiomyopathy. Severe LV global systolic dysfunction, it was about 26% dilated LV cavity, and type 3 diastolic dysfunction. So in the perfusion imaging, we can see the first one, there is a perfusion defect in the LAD territory and also in the RCA territory. And the similar pattern of metabolic defect is seen in FDG cardiac PET. And lateral wall perfusion was normal in and also metabolism was normal. So the fusion imaging here, the fusion imaging shows reverse mismatch pattern with mismatch pattern in the RCA territory, that means in the inferior wall. So in LBB patient with DCM, delayed septal contraction may result in reverse mismatch pattern in MPI and FDG cardiac PET, typically without CAD observed in our first case. But it may present with reverse mismatch pattern with coronary obstructive disease in our second case. This patient after that underwent a coronary angiogram. On angiogram, there was 70 to 75% stenosis in the mid-LAD. Sorry. Last slide. Yes. So there was successful PTCA with stenting to the mid-LAD and RCA was done, and there was significant clinical improvement confirmed by follow-up echocardiogram. So in discussion, the possible mechanism of LBBB perfusion and metabolic defect in SPECT and MPI depends on more than one mechanism could be played in together. That's our coronary artery disease, compression of perforator arteries, endothelial injury, microvascular dysfunction. Sometimes there may be partial volume effect, leads to cardiomyopathy, thin septum and decreased remand, and mechanical desynchrony. So in conclusion, I want to say that LBB present challenges in assessing myocardial viability in DCM with CAD. Reverse mismatch pattern can be present in LBB with or without CAD in MPI and PET fusion imaging. MPI and FDG cardiac PET facilitate identification of viable dysfunctional myocardium. And lastly, identifying viable myocardium through imaging can assist in selecting suitable candidate for revascularization, thereby enhancing clinical outcome. Thank you.
Thank you, Dr. Afroza. It was an excellent presentation and definitely interesting. Question for the panelists.
Thank you, Dr. Afroza Aktar, for your nice presentation. So we know that there are different causes of left bundle branch block. So yes, whether this etiology can alter the myocardial viability, etiological yes, aspects of different types of viability. Number 1 point. Number 2 point, that we see that there are other ways of viability, like patient's clinical presentation, is stress echo, sometimes ETT. So LBB pattern can hamper the ETT interpretation and some other ways of viability assessment. So whether you correlate between all this.
Sir, I have actually this both patients were treated for long times. The first case was treated for about 3 years, just chest pain and palpitation, and the second case was suffering from 2015. But for viability assessment, cardiac MRI was not done for this patient, according to the symptom of the patient. And here I am showing the actual functioning metabolic viability in the functional level, so we can assess accurately. We use two type of perfusion, two type of radio tracer which directly act on myocardial cell and the metabolism of the myocardial cell, so we can assess. And of course multimodality imaging can assess more accurately, but our functioning imaging directly image the actual status of the myocardial cell.
Thank you, Dr. Afroza. My question is, in the first case, you have shown that there was a 1-year follow-up study.
Yes, sir. 1 year just we do by perfusion imaging.
Study.
Yes.
So there was a significant improvement in that follow-up
So second case,
yes.
Significant improvement on second case,
yes.
but first case was more or less similar. When he came to us 1 year back, ejection fraction was 30, and after 1 year around 30 to 35, not much improved, but his clinical symptom persisting and LV cavity was dilated gradually.
So I'm talking about the perfusion study, the first case and the first
Perfusion status is reduced, sir.
Reduced than earlier.
Perfusion status is so reduced compared with the previous one. The first study we saw the small only 2 segment was affected in perfusion imaging, but after 1 year around 4 segment are affected. It may be related to LBB, but angiogram was normal.
Despite that, there was improvement in ejection fraction. How do you explain that?
No, so ejection fraction actually around 30 to 35%, sir.
Okay,
Ecote it was 30, and our functioning imaging it just 35. It may vary, sir.
Sir, we're running short of time. We have to end this discussion right now. Thank you, Dr. Afroza. Our next presenter is